In this video series, we're going to discuss how to position forearm radiographs, and I'll tell you my approach to a patient, and this is our patient here, our wonderful volunteer. As you can see, she's already in a guarded position for her arm, so she's already done half the work for you to start out with. So we'll start off with a lateral radiograph, and you come to your patient, talk to them, tell them we're going to ease your arm up on the cassette, and you can easily change the orientation of the cassette to them. Perfect. So we have it on the cassette, and we're going to take their other arm and hold their wrist and make sure that they roll that wrist just in a lateral position, making sure the radius and ulna are superimposed here. The important part too is to make sure that they drop that shoulder a little bit. Make sure the shoulder and the elbow are in the same plane, and you can do that by bringing this forward a little bit, giving them more room to drop their shoulder. Perfect. So there we go. She's kind of rotated that in. There we go. And I would take my marker and mark it on the inside. And then bringing my unit over, you place the central ray of the patient, or of the collimator light to the mid shaft of the radius and ulna there. And I'm going to adjust the collimation. You will get some of the carpals and some of the metacarpals and some of the carpals. And you want to make sure you have all the way back to the olecranon, all the way back. You want to make sure you have light covering all the way. Open that up just a little bit more. So this is how you would position a lateral forearm view. Okay, so very easily from this, you know, when patients are in pain, again, it's very simple to talk to patients, and it just takes time and practice to get them to going from that guarded lateral position, rotating their arm up a little bit and kind of relaxing their arm down. I've had maybe a handful of patients that I haven't been able to do that, and that was just due to their fracture itself. But a lot of our patients, we can go ahead and talk them into this AP position. So with your patient in this position, we go ahead and have them, because they feel generally more comfortable doing it themselves, we're going to roll your arm up. We're going to hold it up, up, up. There we go, very slowly, very slowly. And while she's doing that, she's concentrating on other things, and I'm going to adjust this. So that way we are in plane for her. Perfect. Rest that down, talk to them, just give them reassurance that they can do this, they can do this, they can do this, and have them relax their arm out a little bit more. Okay, go ahead and let go here. Perfect. And as you see, we're in a straight position, and now we're just going to roll that arm out, just like so. Perfect. So again, I'm going to adjust my collimation. Oops, go back, go the other way. So mid shaft of the radius and ulna, collimate side to side, making sure we don't have too much air on either side of the skin. You want to make sure you catch part of the elbow joint and then again down to the wrist joint. So you're going to get all of those metacarpals and some of the carpals in there. All right, and would put my mark on the outside there. One thing you want to make sure of is the condyles of the elbow. You want to make sure that they are parallel to the cassette plane itself. So if you feel, or if you palpate, if your patient's going to let you, palpate for those and adjust accordingly, okay? Another thing that some patients may do is they may leave their wrist crossed like this. That's a no-no because the radius and ulna cross at the mid shaft. So you want to make sure that you bring that back to an AP position just like that, so the radius and ulna are fully evaluated, not superimposed by anything else. And again, as always, make sure you are at 40. And there we go. Perfect. Oop. There we go. And that's how you position for the AP view of the forearm.